Thanks, Lawrence. So I'm going to go through a number of things today. I have nothing to disclose, and I'm not going to spend time going through this. This should be in your syllabus as well. I do want to orient you, though, to a few things as we move through the talk on kind of basics about the obstetric airway, touch briefly on general anesthesia and obstetrics, hopefully to complement what Lawrence has already talked about, and then move into airway equipment, specific airway algorithms, and how we may best prepare both ourselves and our trainees to deal with this type of event. And the symbols you see here will be reflected in the upper left-hand corner of the screen as we move along. So like many things in medicine, it all comes down to physiology. Every system is affected by physiologic changes of pregnancy. And all of these will contribute to what makes a difficult airway situation in the obstetric patient. Circulating blood volume and cardiac output will increase by about 40 to 50% by term pregnancy. And these changes can lead to capillary engorgement and edema of the oral nasopharynx. In addition, there is a great degree of fat deposition in a normal pregnancy. And breast enlargement can actually impair the insertion of a laryngoscope blade in and of itself. As the gravid uterus moves out of the pelvis, it forces the diaphragm to move cephalad, creating basilar atelectasis and decrease in FRC, a change which is compounded when the parturient assumes a supine position. Pregnant women have increases in oxygen consumption based not only on the metabolic demands of the fetus and the uteroplacental unit, but also on their own increased ventilatory drive. Finally, any pregnant woman above 18 to 20 weeks should be considered to have a full stomach, as we see a decrease in the lower esophageal sphincter tone, and once they're in labor, decrease in gastric motility. Unfortunately, all of these changes combine into a situation where you have a patient that may be difficult to both intubate and ventilate, will desaturate rapidly upon the onset of apnea, and is at risk for aspiration. So our seemingly healthy young woman has become your airway worst nightmare. And while we attempt to avoid general anesthesia as much as we can, and when we see a difficult airway, we can prepare for it, things may change along both the course of pregnancy and throughout the labor course. As Lawrence mentioned, the Mallampati class can worsen throughout a course of pregnancy based on receiving IV fluids, some period of pushing, and certainly we can be worried about the antidiuretic effect of oxytocin when used for induction or augmentation of labor. Mallampati class can change up to 2 classes just from labor itself. Does an epidural impact this? Well, a study was done to look at whether having an epidural can impact the change of Mallampati class. And while I'm happy to report that 30% of patients had some change in Mallampati class, there was no impact between the 2 groups of whether an epidural was present or not. When it comes to difficult intubation in the obstetric population, this is probably around an incidence of about 1 in 30, and this also increases as Mallampati class worsens. About a 7.5 times increased risk in a class 3 airway and about an 11 times increased risk in a class 4 airway compared to a class 1 airway. Mallampati class also comes into play when we look at cases of failed intubation and independent risk factors. One group out of the United Kingdom did a study and identified that Mallampati score increases was the highest contributing independent risk factor. In terms of an incidence of difficult or a failed intubation in the obstetric population, the quoted numbers have ranged from between 1 in 220 to about 1 in 300. And there was a recent large literature review of about 140,000 both published and unpublished cases. And this group revealed a slightly lower incidence of around 1 in 390. Regardless of the actual number, we know that this is a much higher risk population than the general operating room population, up to about 8 times higher risk for difficult or failed intubation. The United Kingdom's obstetric surveillance system has also looked at cases of failed intubation in the United Kingdom over a 2-year period. And they found that there was an increased risk for both maternal hypoxemia as well as maternal morbidity in failed intubations. They also found an increase in the rate of neonatal NICU admission, but this was not a significant finding. Unfortunately, we may also be setting ourselves up for increased liability, or does this matter? The closed claims analysis that most recently looked at obstetric anesthesia compared cases from before 1990 to those after 1990. And while they found that overall the number of claims related to general anesthesia and the respiratory system decreased in the post-1990 group, the number of claims related to failed or difficult intubation did not change. A lot of this is probably related to what Lawrence talked about in terms of our goal to reduce the incidence of general anesthesia and really emphasize neuraxial anesthesia. And our ASA practice guidelines reflect that, that they urge obstetric anesthesiologists to promote the use of neuraxial analgesia and anesthesia, especially in cases where we either suspect or know there's a difficult airway situation. So, in many cases, general anesthesia is reserved for either maternal or fetal emergencies. Unfortunately, we've all had situations, though, where there are contraindications to neuraxial anesthesia, or we have a difficult or failed or inadequate regional technique. And certainly, you can all imagine situations in which you would need to perform an intubation, even if a regional technique had been previously adequate, whether for changes in patient status or for changes in surgical complexity. Unfortunately, this decreased use of general anesthesia has led to a situation where there are really very few true experts in the obstetric airway. And these intubations are happening in sicker and more acute situations, leading to more stress involved. I want to touch briefly on awareness because I think this is pretty relevant to the difficult airway discussion. In the United Kingdom, they looked at all of their failed intubation or cases of awareness over a year period and identified some risk factors that I think are going to look very similar to how our patient population looks, unfortunately. They also more concerningly identified that of all the awareness cases, 10% were seen in obstetric patients. A lot of this comes from some factors that we can all recognize, that we do intubate more patients in emergency situations, that there's often a very short period of time between the induction of anesthesia and the start of surgery, leaving little opportunity to supplement your induction dose with a volatile anesthetic. We often avoid opioids during induction, and more applicable to this talk, these often occur with difficult airways. So they make some recommendations on what we can do to try to address this, which I think are reasonable, apart from maybe the third one. So I think it might be difficult to seamlessly incorporate the discussion of risk of awareness into your typical consent for a neuraxial procedure with your typical obstetric patient. So back to the airway. When we go about actually preparing for this, it's important that we have setup of equipment that's very similar to what you would see in the general operating room. Again, this is a situation where we aren't using this equipment very often in the obstetric population, so you want to have a high level of comfort. This includes having multiple oral airways, multiple laryngoscope blades and handles, hopefully a short handle if you can obtain it, and a smaller endotracheal tube diameter than you would typically use for that size of patient, usually a 6 to 6.5 internal diameter tube. It's also important to have some basic extra equipment available in every room, including a gum elastic bougie and an appropriately sized supraglottic airway. When it comes to supraglottic airways, this is a device that has been promoted throughout anesthesia in terms of difficult or failed intubations. And it doesn't really matter the type of supraglottic airway. Again, it's just important to have something that is appropriately sized and readily available within your labor and delivery operating room. Unfortunately, there are a few considerations to take with this because it's not truly securing the airway in the way that an endotracheal tube can provide. Cricoid pressure, for what it's worth, can be maintained if you want with a supraglottic airway in place. However, if that cricoid pressure in any way impedes the placement of the supraglottic airway or ventilation through the device, it should be released readily. The question of whether a cesarean delivery can proceed with a supraglottic airway in place is something that will depend on the individual clinical circumstances of the case and usually involves a discussion with the obstetrician. There are a few things that the obstetrician can do to decrease the existing risk of or exaggerated risk of regurgitation, including making a larger incision, avoiding fundal pressure, and using a vacuum to help with extraction of the fetus. Again, we haven't had necessarily head-to-head studies of different types of supraglottic airways, but some authors would propose using something like this, an LMA Supreme, or another device that has an extra port through which gastric contents could be suctioned if you so desired. The use of this device was tested in a large study of elective cesarean deliveries that were performed with general anesthesia with an LMA Supreme, and of those 700 patients, none had any evidence of regurgitation. I'm certainly not advocating to use this on a routine basis, but I think that this type of study gives support for the use of supraglottic airways within obstetric airways, and especially in a difficult situation. Similar to supraglottic airways, video laryngoscopes have enjoyed quite a bit of support within difficult airways. While the evidence points to potentially faster intubation, improved initial attempts, especially in inexperienced hands, and the ability of other providers to see what is happening during the intubation events, the literature that we have from the general OR has not quite been replicated to that degree in the obstetric population. There are, however, a number of strongly supportive studies such as this that was published in 2012, which showed 100% success rate using a video laryngoscope for intubations that were suspected to be more difficult than usual, and no failed attempts when a video laryngoscope was used as a rescue device. So again, we don't have anything to say that one video laryngoscope is better than another in the obstetric population. But I think that this evidence strongly supports having a video laryngoscope of some sort either on your labor and delivery unit or readily available, especially if you suspect a difficult airway. Finally, the ASA Task Force on the Management of Difficult Airways released a new practice guideline in 2013 in which they strongly recommended having a portable storage unit or a difficult airway cart where kind of the more advanced airway equipment can be organized and brought in mass to a situation. The ASA did not speak to how many of these you should have in your hospital or whether one should be made specifically for the labor and delivery unit. However, the Canadian Airway Group in 2013 gave a strong stance that any sort of difficult airway equipment that you would have in the main operating room should be readily available for obstetric patients as well. And regardless of whether or not you can justify having a separate cart for labor and delivery, whether this is cost effective, we have to balance the cost versus the potential medical, legal, or emotional outcomes that come with a failed obstetric airway. And if you can't have one on labor and delivery, your obstetric anesthesia provider should be very familiar with what is involved within that cart, where it exists in your hospital, and how to rapidly get it to the labor and delivery operating rooms. Airway algorithms have long had a place within anesthesia, and a difficult airway algorithm is updated frequently by the ASA Task Force. But only over the past 4 to 5 years have we really seen obstetric-specific algorithms come into play. And these have been released not only by United States groups, but Canada, and most recently in 2015, the Obstetric Anesthetists Association in the United Kingdom. And I showed a couple here, and I'm going to use the OAA algorithm to talk through the next few points. So regardless of what algorithm you choose to follow, having the optimized first attempt is of utmost importance. This includes being able to rapidly intubate, putting yourself under the best intubating conditions, and causing the minimal trauma possible. Direct laryngoscopy remains the standard for this first attempt, and using, again, a small diameter styleted endotracheal tube. After that first attempt, or maybe a second, we really need to turn things over to the most experienced anesthesiologist around. And at this point, there are a couple of considerations that come into play. Again, whether or not you can oxygenate or ventilate the patient. Ventilation has always been the branch point that we've used for the traditional difficult airway algorithm from the ASA, but the OAA really points toward oxygenation as an important thing for obstetric patients specifically. I think it's also interesting to note that they strongly advocate for the potential to wake up the patient if oxygenation is possible and it is not a case of a true maternal or fetal emergency. Failing the ability to oxygenate or ventilate, and with continued inability to intubate a patient, we do need to move early towards a surgical airway or an invasive airway. And consulting and gathering our surgical colleagues at this point is important. So it's great that we have these algorithms and protocols, but I think we also need to consider this quote that came from an OAA survey of its members in which they present the case of a failed airway where a supraglottic airway was left in place for the remainder of the case. Algorithms and protocols are excellent tools to help guide our decision-making, but they really can't account for all of the complexities and unexpected things that can happen in actual real-life situations. For example, what happens when you put a supraglottic airway in place and the airway deteriorates after that? What happens if you decide to wake up the patient and now you no longer have reassuring fetal heart tones? Or what happens if you really don't have access to some of this difficult airway equipment? I think the best course of action is to be very familiar with these algorithms and to understand how the progressions go, why they exist, but also keep in mind that clinical circumstances, and especially in labor and delivery, rapidly changing priorities may cause you to deviate from the exact letter of those algorithms depending on the situation. Because, as I've mentioned, we certainly are seeing less of the obstetric airway, and there are many considerations in terms of stress involved. Simulation has been advocated to give exposure and to give continuing education for this type of event. Luckily, the obstetric airway is not quite as rare as malignant hyperthermia, but simulation still offers that safe environment through which you can practice not only the ability to intubate the mannequin with difficult airway situations or difficult intubating conditions, but also strongly offers the opportunity to go through non-technical skills. Again, obstetric airway puts people in a situation in which they may lack experience, they may not be able to prioritize risk factors and to cope with the stress of taking care of not just one life, but also the life of the fetus. And strengthening the ability to be a leader in that situation, to have good communication with the obstetrician team, with the patient, and with the nurses can be very valuable. In addition, simulation can be used to go through debriefings and briefings and to build that same kind of shared mindset that Lawrence was talking about that creates a stronger team when these rare events occur. While ideally we would do this regularly, it certainly will depend on the capability of your individual institution or labor and delivery unit. Again, I want to touch on that this simulation is not applicable just for technical skills, but also strongly can help with the non-technical side of things. When looking at common errors that people make in the obstetric airway, it includes failure to move on from intubating attempts, failure to abort procedures that are not working, drug errors, even failure to call for help or to gather the appropriate equipment. And again, much of this boils down to stressful situations that, and the time-sensitive nature of what we're doing. And unfortunately, goes back to that lack of exposure that many of us see even as practicing clinicians and certainly our residents. You can imagine a resident that's only done 1 to 2 obstetric intubations during their training going out into practice, and now at 2 in the morning is faced with doing this with no help, no other anesthesiologist in the hospital. Unfortunately, many obstetric airways do occur at off hours and thus are often in the hands of more inexperienced providers where the true experienced expert is not available to help. One group has tried to address some of these issues by creating a specific set of scenarios that can train our residents in some of these different types of situations that we face in the labor and delivery unit, some of those unique scenarios. And so they designed 4 scenarios that really address both fetal and maternal emergencies and both the situation where you can or cannot ventilate the patient, as well as an elective cesarean delivery. They ran a number of trainees through this and developed an algorithm based on those different priorities. And unfortunately, the results were not so great when it came to the ability of trainees to move through the steps. In over half the cases, they failed to even do things like call for help or gather difficult airway equipment. But it was somewhat positive that from the first to the last scenario, the overall scores did improve. I think this shows that even with a brief number of scenarios and a brief number of exposures, we can show some degree of skill or knowledge retention and improvement. And this type of simulation, again, can focus not a little bit on the technical side of things, but also on that non-technical side where we're dealing with different ethical priorities and stressors than what we might see in the general operating room situation. So how can we set ourselves up for success with all of these considerations? Well, in an ideal world, we're going to have the ability to fully prepare the patient, do a pre-anesthetic assessment, look at the airway, and go through all of these things like giving pre-medications to decrease the risk for aspiration, having optimal positioning with a ramp, fully pre-oxygenating the patient. But I think in reality, we know that that's not what we get. We get called to meet someone in the operating room at 2:30 in the morning, and it's just you and a patient on the bed, maybe even halfway down the bed. So having a strategy when it comes to what you're going to do if you do see a difficult airway is of the utmost importance. We do have some degree of things like this, tools that are a checklist-based way to have either yourself or someone else make sure we can gather things like help, equipment, move through algorithms. And this is similar to the kind of critical event checklists that have been used for things like local anesthetic systemic toxicity and, again, malignant hyperthermia. Especially helpful for cases or for providers that don't typically deal with this type of event. It's also important to, when you know that there's a difficult airway, again, get in contact with your obstetricians and with your nurses and discuss what that means. Do you have to consider intubating the patient awake? Can you try to get an early neuraxial technique? What equipment do you need to maybe bring up from the operating room? And figuring out who your backup is. During the day, usually there's someone else around, but in the middle of the night, do you need to call someone in if you feel like you're moving towards going to the operating room, if you're really that concerned about the airway? So again, while we try to avoid neuraxial or avoid general anesthesia as best we can by utilizing more neuraxial anesthesia, we still do see it. And unfortunately, at some point encountering a difficult obstetric airway is going to be an inevitability if you do frequent shifts upon labor and delivery. Having this type of information in mind and being familiar with the protocols that exist, the algorithms and how they progress, and walking yourself through what are you going to do if your initial attempt at intubation fails can be very helpful when you actually face this in real life and are in that sort of stressful situation where cognitive biases and fixation errors are certainly a risk for all of us, not just for our trainees. And going through simulation or having frequent refreshers can help with this, but in the end, making sure that you reassess the airway, making sure there haven't been changes from when you saw it earlier, getting help, getting equipment, putting yourself in the best situation possible is the best that any of us can do. And in the end, respect the obstetric airway. Thanks.